So let's go into the final parts of the lecture. We're talking about gait deviations. Knee hyperextension, also called genu recurvatum, because this one is the most common deviation you'll see clinically and is often misunderstood. What you observe, visually, you'll see the knee snap suddenly into extension during stance, or remain hyperextended throughout mid-stance and terminal stance. Sometimes it looks subtle, sometimes it can be very aggressive and audible. You can actually hear the knee lock. The biomechanical mechanism, this is simply not just a quad problem, even though quads are involved. During loading response, the ground reaction force passes posterior to the knee, creating an external flexion moment. Normally, the quadriceps eccentrically control this. With excessive hyperextension, one of two things happen. The patient cannot control knee flexion, so they rely on passive locking, or the ground reaction force rapidly shifts anterior to the knee, creating an extension moment too early. This shifts load to the posterior capsule, the ACL, or articular cartilage. Instead of muscles absorbing force, ligaments do the job. Common causes, usually quadriceps weakness, plantar flexor tightness or spasticity, where the tibia cannot advance, proprioceptive deficits, or habitual strategy after an injury, where locking feels safe. Neurologically, this is extremely common post-stroke or with incomplete spinal cord injuries. Secondary compensations, what to watch for: reduced knee flexion in loading response, an early heel rise, a posterior trunk lean, or reduced stance time on the involved side. Why it matters clinically: this gait pattern, again, increases posterior capsule stress, putting repetitive strain on the ACL. It eliminates shock absorption and increases joint degeneration risk. Patients often complain of posterior knee pain, quote-unquote jamming sensation, or fatigue with walking. Assessment pearls: watch from the side, not just the front. Look at timing. Is it hyperextension early or late stance? Test the quad eccentrically not just an MMT, and assess ankle dorsiflexion. The intervention logic. You must restore controlled knee flexion in loading, improve confidence in knee control, and reduce reliance on passive structures. Corrective interventions. Again, focusing on eccentric quad loading, slow step downs, controlled sit to stands, and the things I have listed. Hamstring coactivation drills for joint awareness, such as single leg balance, perturbation training, or doing balance tasks on foam or a Bosu ball. Again, assessing ankle dorsiflexion and noting if there's any mobility restrictions. And then functional retraining. Using cueing during gait of stay soft and do not lock. If the knee is hyperextending, ask what is the patient avoiding. It's usually weakness, instability, or fear. Excessive knee flexion during stance, also known as a crouch gait. This is essentially the opposite problem and is far more metabolically expensive. What you observe, the knee remains flexed throughout stance. It never reaches near full extension, and it creates a crouched or squatting appearance. You'll often see this bilaterally in neurologic populations, but unilaterally with pain or fatigue. The biomechanical mechanism. The knee stays in flexion, meaning the ground reaction force stays posterior to the knee. The quadriceps must remain active throughout stance, and passive skeletal support is never achieved. This turns walking into a continuous squat. Common causes: quadriceps weakness or endurance deficits, hamstring tightness or spasticity, hip flexion contracture, ankle dorsiflexion restriction forcing compensations, or pain avoidance such as osteoarthritis or a post-surgical candidate. In cerebral palsy, this is often structural and long-standing. Secondary compensations: increased trunk forward lean, increased hip extensor demand, shortened step length, and a slower gait speed. Why it matters clinically: during a crouched gait, it dramatically increases energy cost, overloads the patellofemoral joint, accelerates fatigue, and limits community ambulation. Patients often say, "I can walk, but I get tired really fast." Assessment pearls for yourself is observe how much knee extension is available, not just used. Test quad endurance and not just its peak strength. Assess hamstring length and tone. Watch a sit-to-stand transfer. It mirrors gait demands. The intervention logic. Your goal is gradual restoration of extension, not forcing it. Corrective interventions. Progress quad strengthening through functional ranges, such as the sit-to-stand drill, resisted knee extensions, and/or lunges. Hamstring mobility, if limited, you can do supine hamstring stretches or a contract-relax PNF. You can work on closed chain functional drills, such as sit-to-stands, to progressively lower surface, resisted walking with bands, step-ups emphasizing terminal knee extension, and focusing on gait with upright posture cueing. If the knee stays flexed, the quad never gets a break. That's why these patients fatigue early. A stiff knee gait. This deviation shows up most clearly in swing phase, but the root cause is often earlier. What you observe: reduced knee flexion during swing, poor foot clearance, toe drag, and compensations like hip hiking or circumduction. Talking about the biomechanics, normally knee flexion in swing is assisted by push-off momentum, gastrocnemius recoil, and hamstring activation. In a stiff knee gait, rectus femoris fires too long or too early. Knee flexion is mechanically blocked. Swing becomes inefficient. The common causes: usually spasticity or overacting rectus femoris, quad dominance with weak hamstrings, poor timing, not just strength deficits, and fear-based guarding after injury. Secondary compensations would be hip hiking, contralateral vaulting, and increased lumbar side bending. Why it matters clinically: increased fall risk, increased energy and expenditure, abnormal loading at the hip and spine. Assessment pearls: watch knee motion specifically in initial swing. Compare passive versus active knee flexion. Palpate rectus femoris during gait if needed. Corrective interventions: hamstring activation drills, such as prone hamstring curls or bridging with hamstring bias. Rectus femoris stretching, especially dynamic, standing quad stretch, or a Thomas test stretch. Dynamic knee flexion practice. Marching drills emphasizing knee flexion, stepping over obstacles, or treadmill gait with focus on swing phase. If knee flexion is absent in swing, always suspect timing, not just weakness. Knee buckling. This is one of the most functionally limiting and anxiety-provoking deviations. What you observe: sudden knee flexion during stance, the feeling of it giving way, and patients may grab walls or stop walking. Biomechanically, during loading response, the knee must resist a large flexion moment. Buckling occurs when quadriceps cannot eccentrically control flexion, joint stability is compromised, or neuromuscular timing is delayed. Common causes: quadriceps weakness, post-surgical inhibition, ligament instability, neurologic deficits. Secondary compensations: reduced stance time, over-reliance on assisted devices, a stiff knee, or hyperextension strategies later. Why it matters clinically: these patients are usually high fall risk. They have a loss in confidence, and then they usually avoid activities that they normally enjoy. Assessment pearls: test quad strength in weight bearing, look for apprehension, ask directly about giving way. Corrective interventions: progressive quad loading, such as leg press or resisted terminal knee extension, co-contraction drills, such as wall sits with an adductor squeeze, or functional step drills, and then task-specific retraining: bodyweight supported treadmill walking, or step-through drills with therapist assistance. Buckling is often more about confidence and timing than raw strength. All right, a varus thrust and a valgus collapse. These deviations are critical because they're strongly linked to injury risk and OA progression. What you observe: in varus thrust, knee bows outward during mid-stance. In valgus collapse, the knee falls inward dynamically. It's often subtle, and usually doing video analysis to get it into slow motion will help. Biomechanical mechanism: these are frontal plane controlled problems. Valgus collapse typically reflects poor hip abductor / external rotation control, trunk instability, or poor foot to knee to hip coordination. Varus thrust often relates to medial joint degeneration and lateral soft tissue laxity. Why it matters clinically? A valgus collapse is strongly linked to an ACL injury. Both patterns increase asymmetric joint loading, and both will advance osteoarthritis. Assessment pearls. A single leg squat will tell you a lot. Watch their trunk position and assess foot posture and pronation timing. Corrective interventions. Glute medius and glute max strengthening by doing side-lying hip abduction, banded side steps, or monster walks. Trunk stability training, single leg RDLs, and step downs with mirror feedback. And then neuromuscular control, doing single leg squats with alignment cueing. If the knee collapses inward, don't just cue the knee. Cue the hip and trunk. These gait deviations are rarely isolated. Most patients present with combinations. And your job is to determine which deviation is primary and which is compensatory. This slide is just demonstrating the use of EMG studies to further broaden the point of these deviations. In summary, the knee's behavior during gait is a balance of external load, internal muscle forces, passive structures, and joint geometry. Normal gait has characteristic patterns of muscle activation. Pathologies change both the timing and magnitude of activation. Understanding the clinical interventions, when to use strength, neuromuscular training, assisted devices, especially during which phase and for which muscles. And then the use of EMG and modeling, providing quantitative data to guide intervention, ground reaction force data to help understand what external demands are and how the knee must respond. If you have any questions, please email me, and I'll see you in lab.